We know from increasing research that patient education is a critical part of the best practice management of people with patellofemoral pain. So it may be helpful to work through what this might look like in practice. Often we jump straight to what the causes of the patient's pain are, or how to modify their activity, without taking the time to talk through what it is and what it isn't. One reason this is so important is that if someone has the belief that the cause of their pain is wear and tear, for example, or other unhelpful concepts such as having an injury that needs to heal, then expecting them to exercise or load their knee in various ways without reframing these understandings is not likely. So where can we start? Let's start by getting an understanding of the patient's perspective. In our interview, we can seek to understand our patient. What do you understand is going on with your knee? If you've seen a health professional already, what did they explain? Or we can even ask, why do you think it isn't getting better? Why hasn't anything helped up until now? Your patient might know a lot, or they might not know anything, or they may even have some unhelpful beliefs about what's already going on. So getting a baseline of knowledge and understanding is really helpful here. The next step that can be helpful when explaining patellofemoral pain is to orientate the patient to the knee itself. I like to use a model of the knee to explain that we actually have two major joints in our knee that allow us to move. The main joint of our knee connects our thigh bone to our shin bone. This is the large hinge type joint that allows our knee to bend and straighten. And this joint takes most of our body weight when we're standing or running, for example. We can also link to our assessment findings at this point. From our test today, we've ruled out any problems with your knee joint. Your knee is moving fine, and we can confirm that your pain is not coming from here. The other joint we have, though, with our knee is where our kneecap, or patella, sits over the top of the knee. Although this is a much smaller joint, it has an important role in transmitting forces across the front of the knee, especially the strong forces from the muscle at the front of our thigh. This joint is called the patellofemoral joint, where the patella sits on the end of the femur bone, and it allows the muscles of the leg to bend and straighten your knee and transmit force, especially with tasks like running and going up and down stairs. Patellofemoral pain is the name given to the pain that we get behind or around the kneecap when we've carefully ruled out other causes of your knee pain. This is a very common problem. In fact, it's the most common type of knee pain we see in people who are physically active. The structures that sit in and around the kneecap are really sensitive to irritation. So any sudden or unaccustomed load and other factors can cause irritation to some of the more sensitive structures around the kneecap. Now we can check in with the patient at this point. Does that fit with what you understood or have previously been told? And do you have any questions at this stage? The next step in our patient education is working through the contributing factors as to why they've developed or why they're continuing to get patellofemoral pain. By the patient understanding that their problem is multifactorial with a number of contributing factors, it helps to frame that there isn't really just one quick fix. And it helps the patient understand that the reason behind the management strategies that we'll be using. How you structure this will depend on your findings from your interview and your physical assessment. What has contributed to your patient's symptoms? Very often it will be a history of sudden or unaccustomed loading, such as a change in training or taking on a new activity. It's likely there are other contributing factors too, especially where someone has developed persistent pain. Even though the pain is localized to the knee or the front of the knee, it doesn't mean it's just the knee that's responsible. Research has shown that the function of the muscles around the hip and knee and the positioning of the foot can all contribute to how the knee is positioned and how loading goes through the knee. So these often form part of our management plan too. If the patient has persistent pain, this is where it might be helpful to start to introduce concepts that can contribute to persistent pain, like adaptations to the nervous system. Let's now look at activity modification, as this is often the central focus when we're thinking of the big, most important outcomes of our patient education, especially on day one. One of the big mistakes we can make for those with patellofemoral pain is we don't modify activity in effective ways. We often make mistakes like telling people to take it easy or rest their knee, or other phrases and approaches that can be at best unhelpful and at worst really delay someone's recovery. So let's look at how we can help guide activity modification in a specific but flexible way. We can work with the patient to establish some guidelines about what level of activity can be tolerated in a way that doesn't aggravate their symptoms. In many cases, this might be keeping the pain below a 3 out of 10, or maybe even more ideally below 2 out of 10, and making sure that the symptoms settle within an hour of the activity and are not worse the next day. It might be working with the patient to come up with a list of the more perceived safe activities that they can do at the moment that they know won't worsen their pain or set them back. This might be modifying their running distance, or even just sticking to cycling or swimming if pain is more severe. At this stage, if someone is erring away from any activity, it might be helpful to go back to talking about what the pain is, and that activity is still safe, and pain in this situation, especially low levels of pain, is not a sign of tissue damage, and give the patient some safe parameters to be working within. Now that we've reached a happy medium with the patient about what's okay to do at the moment, it can be really valuable here to zoom out to the bigger picture. What is the bigger plan? We might be able to use some of these guidelines around acceptable levels of pain to build up a plan to how the patient might gradually return back to their desired level of activity. Lastly, this education around patellofemoral pain is a gradual approach. It's probably not realistic or even really helpful to try and cover all of this on day one with your patient, especially when you have many other management priorities. So think about how you might build on this education from day one to any follow-up consultations with the patient. It might be helpful here to look at our video on best practice patient education to see how we can build on patient learning over time, and the link is down in the notes. So let's summarise our patellofemoral pain education. Firstly, patellofemoral pain is an umbrella term, but it doesn't mean we need to be vague. We can actually be really specific about what's going on with the patient's knee, outline what we've ruled out, and really link this back to what's contributed. Patellofemoral pain is multifactorial, so take the time making sure the patient understands what has contributed to their development of pain, and therefore how this links to how we will be best managing it. Lastly, be really specific with activity modification, especially where someone has had challenges with modifying activity and managing their pain. Come up with both short-term strategies and link these back to the patient's longer-term goals. This helps keep the patient on track, allows them to take the reins of managing their condition, and maintains motivation.